Welcome to Marney Reid Presents Connect to Develop, where we provide insight from healthcare leaders on the hottest topics and trends. Hello, listeners, and welcome to our continuous series of podcasts talking about what it takes to build an best-in-class ambulatory surgery center. Going forward, I'll just call this an ASC. Today, we have a returning guest who shared advice on how to build a concierge medical practice and is one of the top ASC clinical operators in the country. Welcome back, Janet Carlson.
Thank you, Marnie. Thrilled to be here.
We also have an incredible ASC expert and longtime friend, Dr. Neil Badlani, whose experience in ASCs goes from owning and operating in his local ambulatory surgery center to, at one point for several years, he helped develop and grow as a chief medical officer, a large surgery center company, and learned some great best practices from this experience. Thanks for joining us, Neil.
Thank you, Marnie. It's great to be here with you guys to talk about this fun topic.
I'd like to begin by unpacking the differences from building and running a multi-specialty, so not just orthopedics, not just spine ASC, versus an orthopedics and spine only ASC. Janet, from a build-out standpoint, what's the ideal footprint for a multi-specialty ASC? And then how would that differ if you were focused on just building one for pain, ortho, and spine?
So the main thing that I would lead off with for this topic is the size, the square foot of the OR. So you need a minimum of, I would argue, 600 square feet, just so you can accommodate the back tables and trays and instrumentation required for the higher acuity multi-specialty cases.
Yeah, I know when we do spine cases, there's a big expense that goes into it, and we're looking at microscopes and Jackson tables. When you have your big orthopedic cases like total joints, that's a lot of infrastructure and capital expenditure. So I think those are things you really have to consider first from the perspective of the build out.
Agree. And additionally, for single specialty, like you mentioned, Marnie, for pain, you could get away with a smaller sized OR and arguably have more ORs in that same floor plan.
Yeah, the orthopedic surgeons, particularly for spine or joint, we want a lot of space, right? Like we have back tables with 5 trays and we need some elbow room. And so, I think it makes a big difference when you're thinking about what cases are going to go in the rooms. So if you have a multi-specialty center, you need to have a big room for ortho and for joints. If you have, ophthalmology or other things, then you could have smaller rooms. So you need to think about your layout. They may not all need to be the same size, the rooms. So those are all factors to come into play. So really the design of the center is really dependent on what the specialties are going to be.
If you're building it, let's say, you've got 4 of your buddies in the same area, you've all talked, you have good clinical outcomes, you get along well, you've, found an ideal place, but really let's just say there's, we'll call it 3 orthopedic surgeons, 1 plans to do joints, you've got 1 spine surgeon, and then maybe you've got, a pain doctor, maybe you've got a few ophthalmologists. What is an ideal size in terms of ORs? Because oftentimes I will find out that a beautiful state-of-the-art surgery center is kind of in trouble, and they're either really, really trying to recruit people, or they're really, really trying to figure out better payer contractors or such, because in my mind, they've kind of overextended themselves and they thought we just have to build this state-of-the-art center and surgeons will flock to it. And that's not necessarily the case. What is the ideal size to start off with so you don't get over your skis and, quite frankly, find yourself in a ton of, real estate debt?
I'd love to hear what Neil says because I have an answer as well, Marnie.
Well, I'm going to ask Janet for the answer in terms of the size because I don't know the room things, but I'll just give you the perspective from the surgeon who's been in surgery centers for a long time. Like surgery centers, if you're going to be successful, it's a cost control play, right? Like building these huge centers, like very expensive, spending tons and tons of money. That I don't think that's really the way anymore to win in the surgery center business. Like you have to embrace the fact that you're controlling cost. You have to be able to go to the payer and say, we can do this for less money, and that's why you should send us your cases. So I think just going into it with the thought of we're going to spend a lot of money and attract doctors, probably, that may have worked in, 10 years ago when you got these great out-of-network reimbursements. But now I think the successful surgery centers are very cost conscious. The doctors buy into that. And so even from the start, I would go with what is economical? What is efficient? How can we save money? That's where we're going to be successful.
Agreed. And I would say to start, Marnie, a 4 OR, 2 procedure room would be ideal. That would be contingent on the number of surgeons that you had. And if you could have the pro forma with actuals, volumes, and acuity of surgeon cases, you can then kind of reverse engineer it.
So across the board, irregardless of it's ortho, pain, and spine only or multi-specialty, you feel like 4 operating rooms of various sizes and 2 procedure rooms is the ideal?
Well, I'm saying it's a good place to start because you could do your pain cases in the procedure room, your lower acuity, even I would say, carpal tunnel, upper extremity, that sort of high volume, quick turnover sort of case. And then have the larger 4 rooms for a surgeon to flip into maybe a spine doc is doing cases that day along with a total joint doc. So that would be an ideal situation to start with in both scenarios, frankly. But for the multi-specialty and the MSK ASC, I would make sure the design is ready for expansion when you go ahead and design and build the first footprint.
I think so much of this is dependent on, the group of surgeons that you're bringing in, right? I mean, if you have 6 or 7 busy surgeons, you may be fine in a two OR surgery center, again, like being efficient, cost. The centers that I've been in that I think or have seen have sort of been really the most successful, the most harmonious, or probably around 8 to 12 people, sort of around 10 people. I think that, you need enough surgeons to make it busy. But if you have so many people, then you sort of don't hold each other accountable the same way, right? If you have 8 or 10 people
Correct.
and they all kind of know each other, then people sort of feel compelled to do a good job, to bring their cases there, to work together. If it gets really big, then you get guys that they sort of go off and do their own thing and maybe don't contribute as much, and it's hard to hold them accountable. And you want to be efficient. I think most surgery centers, you have unused capacity, right? So if you have 4 ORs and you're really only using that 4th OR 20% of the time, that's not the best situation. So I think like really knowing what the partnership is and maximizing the way you can work together in less rooms is best. But like you said, room for expansion, a great problem to have, to be, we're 10 really busy people. We're really successful. We've got 3 great surgeons we know that want to join us, and we just need to be able to build one more room. That would be a great problem to have 2 years into your surgery center, right?
So I would design with that in mind to have a larger footprint on the initial build out, and then you could add the ORs, or you could turn procedure rooms into ORs as well.
Janet, that was a perfect tee up, and I'd like to continue with you. Walk me through SPD, because as someone who helped build out a team where they went around and they assisted facilities who were for the first time building out high acuity procedures like total joints or spine or cardiovascular, sterile processing was really, really critical for that. So if you're, you get the ideal scenario where you can build this from the ground up. Let's say, to Neil's point, you've got 6 to 7 really cohesive physicians, multi-specialty. You're looking at doing 4 operating rooms. Maybe you've got 2 operating rooms that are big enough to do joints where they can flip, or big enough to do, spine where maybe spine is flipping, or, you've got joints in one room and spine in another room. And, you've got a couple other cases going in the other 2 ORs. How do you build SPD? What do you put in it initially? And what do you preserve room for to add as you get busier?
Great question. So you obviously have the clean and the dirty side. And so we can start with the dirty side, where once a case is done, you receive the instrument. They've been sprayed with enzyme on the back table, covered and carried to the dirty part of SPD. Then we begin processing those instruments. We need a large 3-section sink that can hold the cleaners and the solutions that we need to rinse and clean the instrumentation. Once we've done that by hand, we then have to place the instruments through a washer, which connects the dirty side to the clean side. So it's like a really large dishwasher for instruments in the wall between the 2 sides. And then the clean side, the sterile side, they will open once the cycle is finished, they will open up the washer, remove the instruments, and then go ahead and pack them up and place them in the sterilizer to sterilize them. And so when you do spine and total joints, you have many, many trays. And so you have to make sure that your sterilizer is large enough to hold multiple stacks or layers of trays so that you can optimize the utilization of the instruments and also have an extra set of instrumentation available for surgeons. So you don't have any sort of operational inefficiency. So for example, if I had 4 total joint cases, I would want to make sure I had at least 5 instrument sets. And so this sterile processing is key in the clean side to have extra space to add a sterilizer for that potential future growth.
I think the stuff that Janet said is so right on point, right? From a surgeon perspective, we see the dirty stuff go and we want the clean stuff to come, and we don't think about all of that. But just, the surgery center, like we said before, it's about efficiency and it's about volume. We leave the hospital and go do cases in the surgery center because we want to be able to do more cases in less time, right? And so it's always, frustrating when you get in those situations where you're ready to slide into the next room, but the trays aren't ready because they're sterilizing them from another case you already did before. So just like you said, having the capacity to take care of 2 or 3 cases that are need really the same instruments going at the same time, and having the foresight to know, okay, we need an extra tray. Just like you said, I mean, I wish you were at my surgery center on the days where
I do too.
When I said, hey, I'm ready to start this case. And they said, well, the spine tube set is still cooking. And I said, well, I thought we had 2 tube sets, right? But there's just never enough because we finished one too quick and before they turned it over. So you need people there that understand the flow and keep things moving, just like you said.
So everything comes down to operations. I feel like clinical excellence is just a given. We often see these ambulatory surgery centers that start off with no orthopedics at all, and then they are successfully, able to recruit a couple of orthopedic surgeons, and now they want to launch orthopedic bread and butter cases, or even launch, high acuity like spine or joints. What are the first things from an operation and clinical standpoint that facility needs to do to prepare for this brand new service line?
Another great question, Marnie, and I could talk about it for a very long time. But to be succinct, you want to make sure that you have the OR space to accommodate the instrumentations, the tables, the large C-arm for imaging, and then that flows right into SPD. Do you have the sterilizers capable of handling and managing the spine, the total joint trays? And, that's something that a lot of people don't consider when they say we're going to add or we're going to add spine to your. They haven't even looked in your sterile processing. You don't even know if they have storage for tray placement adequate enough. The next key thing, though, when I've onboarded these to new surgery centers, these different service lines, is staff training. A lot of them have a lot of fear and trepidation because they were hired for one thing, let's say, urology or ENT, and now we're adding higher acuity spine and orthopedic cases. There's a lot of fear of the unknown. And so getting ahead of that with staff training and preparing them for a higher acuity, meaning a longer patient throughput time, is a key consideration.
I'll totally add to some of that. I think that for years, people think of spine surgery and total joint surgery as these huge surgeries that are done in hospitals and require months to recover from. And so when you're talking to a patient about surgery, you and your whole team needs to buy into the fact that it's totally fine to do a total joint or to do a bread and butter spine case in a surgery center. And so your front desk needs to understand that. Your PA needs to understand that. The people at the surgery center need to understand that, because you'll have people say, oh, you're doing this outpatient, so if everybody kind of buys into that mentality and we do it the right way, then the patient feels at ease and everyone's on the same page. I think when you're bringing in those service lines from an orthopedic standpoint, I think spine surgeons and joint surgeons, we do feel probably more comfortable if you're already doing some bread and butter orthopedics like sports cases, knee scopes, shoulder scopes, carpal tunnels, right? I think coming to a center, knowing they're doing that would make me feel a little bit better about starting to do spine in the center rather than just coming into a place that's maybe doing ophthalmology or GI and then jumping straight into joints or spine. So, and then for us, like when we come into a center as a spine surgeon, we tend to demand a bunch of things. Like we want a microscope and we want a Jackson table and maybe we want a robot. So again, the partnership needs to come together and think about what really makes sense. It may not make sense to get a Jackson table right away because you can do it on a Wilson frame. It may not make sense to get, a robot. You're just going to have to do it a different way. So those are really big decisions to make because the capital expenditures is so much. And I wouldn't make those right away just to attract a spine surgeon. I'd try to, be smart about how you add those.
Agreed. And don't forget your cooling vest.
Yeah, we don't like to be overheated when we're operating.
Exactly.
Yeah, we need comfort.
Mm-hmm.
I hear a lot about, critical components, alignment with physicians, understanding that this is a cost containment, area, not being crazy and saying, I need the world just to do, one case per month or kind of thing. So Janet, let's look at the staff, right? Because we also are all looking for a service line champion. When you're hiring, whether that's hiring to backfill roles, hiring to supplement, a gap in, knowledge or skill set, what are you looking for besides just experience or whatnot? If I'm an ASC administrator out there and I'm listening to this and I'm saying, hey, I'm about to start the service line, what kind of intangibles are you looking for, especially if it's something as critical as like a director of nursing or, OR manager or something?
Depending on the size of the ASC, Marnie, will determine the leadership needs to help champion adding on a new service line like orthopedics and or spine. So I look for the clinicians, specifically the nurses that have experience in the perioperative area or the interventional area. They're used to the process of a pre-op, intraoperative, and then a recovery PACU phase. That is something that is invaluable in an ASC, and you can teach it to people, but it is very helpful if somebody comes with that knowledge firsthand. I do look for a director of nursing that can drive initiatives, be the champion for this new service line, and then get on board and actually work through the process themselves and demonstrate leadership by doing it themselves. So those are some of the key things I look for. But one thing I also wanted to mention was a partnership with anesthesia. You need a strong anesthesia partnership to carry the load for you for your needs in the preoperative phase to do regional anesthetic blocks, as well as the intraoperative phase, obviously placing spinals for total joint patients, and then in the PACU phase to help manage the pain and successfully discharge the patient.
Yeah, I think that's all really important. I think that it's a hard to beat experience, right? Like if you come in and this person's done this for many years, that helps. I think the surgery center is a place where there's a culture of cooperation. I mean, another reason that surgeons want to leave the hospital and go to the surgery center is because most of the time we're owners in the surgery center, right? So we really care how it's run. And we often feel like we're treated more like a customer at the surgery center than we are at a big hospital system, right? So the nurses and the OR manager know that, they basically want to keep us happy. They want to keep things efficient. And same thing from us. Like if we have a good nurse, if we have a good manager, we want them to stay with us. It's so much easier to keep a good person, than to try to lose them and have to find somebody like them. So really just kind of a collaborative, cooperative work environment. That's what the surgery center should be. Sometimes in the hospital, we feel like it's not like that. Like we're being told what to do by the OR directors and the managers. And, people they're just there and clocking in and clocking out from 7 to 2 or 3, right? The surgery center is different. Like everyone's there. You want to be efficient because everyone's leaving when it's done, like whether it's done at 11 a.m. or 4 p.m., we're leaving when it's done. So that just we're all on the same team.
It's all about culture.
Yeah, absolutely.
Okay, so Neil, very rarely will a group of physicians get together, build out an ASC and go, you know what, we're bursting at the seams. We don't need any more, surgeons to come on board or whatnot. What are some things that, let's say I'm a physician out there, I'm an owner in an ASC, and we're looking to bring in, 1 to 3 more surgeons. What red flags should I be looking for when interviewing physicians before we not only give them block time that's so precious, but we maybe even, sell them equity?
Yeah, that's a great question. Unfortunately, I have been in situations where, there's people that are in the partnership that are really causing a negative effect on the partnership. So I think that's very, very important. The first thing I would say is I would really err on the side of caution with bringing somebody in. Like if somebody feels like this person is a red flag because of something to do clinically, or probably more often than not, something where they're just sort of overly financially motivated. I mean, all of us are financially motivated. That's not, that alone isn't negative. It's just financially motivated in a way where you're looking at, the money over doing a great job for your patients, or financially motivated in a way that, you're going to take advantage of others. You're more interested in your own personal financial take home rather than doing what's best for the whole group. For example, if you come in and you're using a certain type of pedicle screw, and you're a consultant with that company, and so the pedicle screw costs $500 more to the surgery center, but you make that money for yourself, that's something you have to disclose, right? Like, because you're making money from the pedicle screw, but the whole surgery center is making less money on that case, right? So you want people that buy into the fact that you're all there working together, you're all there to be efficient together, you can all make money as a group. So if you have people that you have those reservations about, I would not bring them in. It's so much harder once someone is brought in and they don't get along or they don't do what everybody else does to get them out than to bring them in. So I would certainly ask around. If it's not somebody you know very well, try to get a sense of them. And really, at the end of the day, it is best to bring in people that you know, people that you have some comfort with. Maybe it's someone that someone's trained with, or worked with in some other hospital. You really want, I think, known people, not just people with big volume. We're often tempted to say, oh, this guy's got the biggest volume, let's bring him in. That may not be the best in the long run.
Janet, let's stick on volume, because what was very interesting to me is, especially when looking to bring another physician on, there's so many considerations. If you're looking for a joint surgeon or a spine surgeon, there's not only giving up precious block time and completely changing the entire potentially workflow of a physician that's already figured out their clinic schedule, their hospital operating schedule, their ASC operating schedule. Now you're asking them to give up precious block time to make room for certain cases which need to be done on certain days of the week and at certain times of the day. And so a lot of people look and they go, well, we pulled some numbers, or we were told by the device rep that this surgeon does 500 cases a year. And in no way, shape, or form are they going to bring nearly, those 500, and especially not in the first year that they're doing it, especially if joints or spine aren't being done. Janet, can you share with the ASC administrators who may be listening out there how you truly validate and get a solid pro forma? Because to Neil's point earlier, this is a cost containment scenario, and you need to really optimize your time. And the last thing you want is thinking that you're bringing this, huge high volume person that truly, when you get down to it, can maybe bring 3 a month.
Yes. So I do ask for their actual data. They can provide it to me for the last 3 years. And I use that to plug in the numbers of my performa, so I can look out into the future and see that, okay, we're going to start this surgeon with this block time, and we'll ramp him or her, and we'll grow into additional block time with a flip room if they continue to utilize their block time, optimize it, and if they're consistent with their commitment to the surgery center. Those are considerations there before I'm going to pull the trigger and spend hundreds of thousands of dollars on capital expenditure for equipment and instrumentation, things like that. Not to mention the labor spend for training the team to be able to manage these new patients.
Yeah, I mean, there's a lot of trust involved. Like these partnerships, everybody really has to trust each other. That's what makes them successful. Everyone is doing their cases like they said they would do them at the center. They're not double dipping in 2 or 3 centers. You really got to be able to trust each other and keep each other accountable. when I went and looked at practices to join and surgery centers and stuff, you want to find the place where the busiest people, like the leaders in the practice, are willing to take just a little bit less, right? Like if you're in it and you do 10% of the business, but you have 9% of the equity and you're kind of the senior person. I mean, that's the type of leader you want in your surgery center, right? Whereas a lot of times we go out and we see, the people that have been in practice for a while and their volume declines and they own 10, 15% and they're only doing 3% of the work and they're not willing to give up shares. I mean, that's not the type of place you want to be in. You want to be in a place where, everybody's as fair as they can be. And really the senior people, the leader people are the ones that set the tone for that.
Neil, what, if anything, changed in the way that you looked at not only ASCs in general, but the way that you personally interface in the ASC or with your partners when you went from being owner, operator in an individual ASC to taking on a C-suite role for a large growing company?
Well, there's a lot of good things about it. I think what I took from it was trying to really understand what makes physicians want to come and be at the center, right? So trying to put together places where, like we said, have great culture. As I said before, like making people understand that it's really like going to be efficient if you think about your cost, like how much are you spending on each case? So I think when I became into that role, I realized more and more how we have to control cost and how the doctors have to understand the cost. The doctors have to take responsibility for that. I have a senior partner that likes to start operating at 10 a.m. and sort of operate until 2 p.m. And he wants 2 rooms and he's a great guy. I mean, I love everything about him, but it's just not efficient, right? So like when you're his junior partner, it's one thing, but when you're sort of in a leadership role in the surgery center, I mean, you've just got to say, this doesn't really work, like you can do this, but you got to do it in one room, right? So just thinking bigger picture about cost and efficiency and having a good culture where people work together. That's what makes the surgery center successful.
Janet, what will make or break a multi-specialty facility?
I think when you commit to too many service lines up front, you are taking on unnecessary risk, meaning you want to be all things to all surgeons, and that's just not feasible. You have to be realistic in your expectations of what service lines go well together. For example, orthopedics, pain management, spine, those go beautiful. I call them the Holy Trinity. They work well in an ASC space. But if you're going to say, we're going to also add ophthalmology and urology and ENT, then you've spread your resources for all these different instrumentation and equipment and staff training needs all over the map. And it's just already set up to be a little messy and potentially not succeed the way that your pro formas were indicating.
Neil, any thoughts from that? I don't know if the company that you were involved with was musculoskeletal specific or it was multi-specialty or a little of both.
Orthopedic pain and spine together is great because then you're referring to each other, right? I mean, it's just a natural pattern that we're sending each other patients and referring to each other. So that's great. I think in the centers that I've been in that were the most successful, obviously they're mostly based on musculoskeletal. And if we add people, just in my own experience, we've had some luck adding ENT to the mix. I don't know why that seemed to work out for us. That seemed to be better than certain centers I've been in where we've had sort of ophthalmology or GI. I've seen centers like that, and I think those maybe are not as great with orthopedics. I think that there was a center that my partners were involved in really before I started, and it was a large multi-specialty center with maybe 20 surgeons and all of these service lines. And I think a lot of the downfall of that center becomes just the economics of it. If the orthopedic cases and the spine cases are much more profitable, the equity table is complicated, right? If the ophthalmologists have the same share as the spine surgeons, that doesn't always work. And it's hard to really balance those out sometimes when you have so many different specialties. It just becomes more complicated. So that large multi-specialty center that I saw them be a part of, really, that was the downfall, was just the inequity of the revenue that the different specialties brought to the center and how it was hard to sort of have an equity table that really continued to reflect that properly.
That's always a big conversation when you're bringing physicians to the table representing different service lines, is what their expectation is for share ownership. And if they understand, what they're bringing, what their performance says, you could always start by adding a physician with a certain minority percentage of interest of shares, and then potentially offer more shares after you give them a time trial saying, let's see how you do in the first year. Are you utilizing your block time? Are you releasing it when you're not going to use it so somebody else can use it and optimize that OR availability? So things like that, again, fit right into the component of the culture, the communication, and the collaboration.
Janet, if someone's going for something like an advanced certification from either, Joint Commission or trying to get a Blue Cross Center of Distinction for joint spine, where do they begin?
Great question. So Blue Cross, Blue Shield, Blue Distinction has a certification of excellence for spine in the ASC, and they also have one for hip and knee. So you need to go online and look at the Blue Distinction guidelines, and they have a hyperlink for the one that you're specializing in, the one that you're trying to attain. And you need to read the guidelines because it's based on the case mix that you have. For example, for spine, it's also based on the acuity and the volume of cases you have already performed. So they want to make sure that you have done these for a while and that you have had successful outcomes. You haven't had adverse patient events. You haven't had postoperative infections, patients going postoperatively to the ED for pain management. So they're looking for you to have established a program like spine or total joints before you can apply. It does require an application fee, and then it's an online application that you fill out. But it is something that if you are doing this and doing it well, that you can achieve and then market to your community and to your other payers to say, look what we're doing. We're holding ourselves to a higher level of clinical outcome, patient expectation of care in our surgery center. We're also controlling cost. So it makes a compelling conversation with the payers.
Let's continue on that payer thread. Have you been successfully able to get things like bundles or higher case rates for your physicians in your center once you've achieved accolades like this?
Yes, I have. And I've actually shared data with certain payers quarterly on my total joint outcomes. So they're looking to see, did I have patients go to the ED? Did I have any postoperative antibiotic utilization? So we held ourselves accountable that way. In doing so, in agreeing to that accountability, they were willing to give me a bundle for a total knee, for a total hip, which was excellent. And then I was working on a total shoulder as well. So you can use that to leverage the conversation. And then you and your surgeons and your leadership in your ASC with anesthesia, you manage the bundle from there and how to pay people out of the bundle.
That's fantastic. So Neil, if you can look into your crystal ball and give us your prediction of the future of ASCs, what do you see for us?
Well, Janet mentioned bundled payments, right? So that's actually something that we're doing now as a private practice. It's hard for us to compete sometimes with like the bigger systems here and the bigger groups. We're still a small group, but we can compete on cost and we can compete on quality. So we go to employers and we say, if the patient needs a 1-level disc replacement or a 1-level ACDF or something, we really understand the cost. We can get the patient and we can do it for less and we can still do well for the surgery center and the physician. So as I said before, I think from a financial perspective, it's all about being efficient and controlling cost and keeping our implant costs down. I think from like a medicine perspective and a technology perspective, we keep getting better with our technology, with the way we do spine surgery, putting in screws, different techniques that we use, different bone graft that we use. There's just so many advancements that allow us to keep doing these cases in the surgery center that we couldn't do 10 or 20 years ago. And so I think overall, what that's leading to is the physicians that want to be involved, it's giving them some control back of medicine. Like I'm controlling the cost. I have more control over the patient in my own center. And I think that it's an opportunity to continue to sort of decentralize healthcare in a way. It's, surgery centers are classically a disruptive innovation. You're taking a surgery that was done in a hospital 10 or 20 years ago, which is essentially like a tertiary center that's costly and inconvenient with hard parking to go to for a patient. And now you're doing it, at a smaller, efficient place for lower cost with like a better outcome for the patient and a more pleasant experience for the patient. And so that's a disruptive innovation to the hospital system, and it leads to the decentralization of healthcare. Now you can do these cases in a convenient location. And that's what happens to a lot of industries. If you look at computers, we had mainframe computers, and then we had large PCs. And over the years, now we do everything on our phone, right? So the same thing happens to a lot of industries, and it's happening in healthcare, just decentralization, more convenient, cost control, and physicians continuing to sort of be involved as leaders, which we've lost a lot of the physician leadership in medicine over the last couple decades. So the surgery center is a way for us to kind of control some of it again.
I love that. Janet, anything to add for your prediction of ASCs in the future?
The future is very bright, Marnie, for ASCs. I believe it is the site of service of choice. I believe surgeons are going to consider coming out of employment, no matter what phase of their career they're in, whether they're early, mid, or late careerist. I'm seeing more and more surgeon interest in the ASC model. And so this is the place where you can come and you can do research if you'd like at an ASC. A lot of people don't know that, and you can do it successfully and you can still publish. The flexibility in an ASC is what's so exciting about the future for this care service.
Well, this has been absolutely incredible. Thank you again, Janet and Neil, for joining us.
Thank you so much for having us. It was great to talk about it. It's a great topic to continue to learn about. I'm still learning about it. It's a big part of the future of medicine. So it's great to talk about it here, and great to be with experts like you, Marnie. I mean, you're an expert on ASCs as well. Janet's an expert. So great to be with you guys.
Agree. Thank you, Marnie. Always a pleasure, Neil. I love talking about ASCs, as Marnie well knows.
You're the best, Janet. If you'd like to learn more about Janet Carlson or Dr. Badlani, please check out their bios in the show notes. Thanks for listening to Connect to Develop. You can find more interviews and Marnie's Minutes on my YouTube channel at Marney Reid Presents.